is a
Let's do
huge
it.
honor for me today to be podcast interviewing Dr. William Nudera, DDS, MS, an endodontist from Bloomingdale, Illinois. Thank you so much for coming on the show today.
It's
So,
my pleasure. I'm thrilled to be here.
so Dr. William Nudera earned a DDS from the University of Illinois at Chicago, College of Dentistry in 1999. Upon graduation, he served the United States Air Force Dental Corps, where he completed a one-year AEGD residency program. During his time of service, Dr. Nudera received a National Defense Service Medal for his involvement in Operation Enduring Freedom. Thank you very much for that, sir. And was awarded the title of Air Force Dental Officer of the Year in 2002. Following his service, Dr. Nudera returned to Chicago, where he continued to practice general dentistry while pursuing an education in endodontics at the University of Illinois at Chicago. Dr. Nudera completed his endodontic training in 2005, earning his endodontic specialty certificate, as well as a master's degree in oral sciences. Dr. Nudera is a diplomat of the American Board of Endodontics. He has several national and international publications, including multiple scientific research contributions to the Journal of Endodontics, and a chapter in the endodontics textbook, 3D Imaging in Endodontics. Dr. Nudera maintains a full-time private practice limited to endodontics at Specialized Endodontic Solutions in the Chicago suburb of Bloomingdale, Illinois. In addition to his full-time practice, Dr. Nudera speaks nationally and internationally on a variety of endodontic topics. Dr. Nudera currently holds a faculty position in the Department of Endodontics at the University of Illinois at Chicago College of Dentistry. He is a member of the ABE College of Diplomats, American Association of Endodontists, American Dental Association, American Association of Implant Dentistry, Illinois Association of Endodontists, Illinois Dental Society, and the Chicago Dental Society. It is just a huge honor to have you on the show today. I'll start off with this. It just seems like when these kids come out of school and they got $350,000 in student loans, they're going to have to do some endo, because endo is one of those profitable procedures. You have to sell bleaching, bonding, veneers, and most dentists aren't good in sales. Most dentists don't even like sales. But a toothache, they're coming to you. They're already sold. Can you fix this? And it really scares me how many kids come out of dental school and just say, look, I hate endo. I'm not doing endo. I want to go into sleep apnea or Invisalign or whatever because I hate endo. What would you say to a kid she's 25 years old right now, she's driving to work, she's listening to talk radio, which is what a podcast is, and she's saying, I don't want to listen to endo because I hate endo and I'm not doing endo. What would you say to her?
Well, I think that it's very common for dental students to leave their 4 years of training in undergrad kind of not knowing a lot about endo, other than maybe not to be dangerous to some degree. Because we've got a lot of experience with endo, and I think when I speak with other my colleagues, it's really common for us as endodontists, when our experience when we left school, we may not have liked it too much either. I left school and I was a general dentist for several years, and I didn't really understand endo either. So all I can do is maybe comment on how I decided to get to like it and how I got better at it. And the key moment for me was building a relationship with an endodontist who was willing to mentor me. So we leave school with this almost cookbook approach. They tell us what to do, but don't really go into a lot of detail of why we need to do it. So when we leave with this cookbook approach, then and not understanding why, then we don't know how to get ourselves out of trouble if step one doesn't work or step two doesn't follow step one appropriately. So I would encourage that young student who wants to do endo, or maybe is afraid to do endo, to find your local endodontist and see how willing they are to mentor you to understand these, what I call core concepts and principles to understanding basic root canal treatment. Because once I figured out the understanding of these core concepts and principles, I was able to achieve much more predictable results in a shorter period of time. And I remember it was when I was in the Air Force. I got hooked up with an endodontist at a base that I was at, who saw me struggling with endodontics and root canal treatments. And we would go over every single case after I got done. And he'd go over the things he liked, he'd go over the things he didn't like. And more, I'd take some cases to him, and I'd say, wow, look, Doc, I got lucky on this one. He goes, no, Bill, you're not getting lucky. You're just getting more predictable, and you're understanding better. So the key to understanding endodontic is just that, understanding. So we could read. There's a lot of resources out there now to help us better our skills. When I got into being an endodontist, I decided to dedicate my profession to this because I loved it so much that I wanted to learn every aspect of it. Now, for that student that just graduated, do they need to know every aspect of it? Well, maybe not, but certainly understanding is critical, and education is where it begins.
So most of these students think, well, I need to hop on an airplane and fly across the United States to go to an endo course because they think that if they went to an endodontist, the endodontist would think in fear and scarcity and think, well, I'm not going to help you learn anything because I want you to give me all your patients. What percent of endodontists do you think, if these millennials knocked on their door, would think in fear and scarcity and say, get out of here, I'm not going to teach you how I make a living, just send me all your patients, versus what percent of endodontists would think in hope, growth, and abundancy, and say, "Sure, let's spread the wealth of
Well,
knowledge."
I don't have an exact percentage for you, but let me give you my example here. When I opened my practice in 2006. Now, I opened up in a very saturated area in the suburb of Chicago. There's an endodontist in every single town around me. Another one that was in town with me. We decided to. I'm with a partner. We decided to open our practice here. And what the hardest thing for me when I opened my practice was to try to change referral patterns. These dentists in the area, we're creatures of habit. We want to do the same thing all the time. So how did I do that? Well, what I did was I went around to every general dentist in my area and the surrounding areas, and you know what I did? I taught them how to do endo, which is counterintuitive for an endodontist to go and teach the referrals how to do endo. And lo and behold, guess what? They realize that, hey, maybe this is case that gets beyond my scope based on what Dr. Nudera was showing me. So you know what? I'm going to give it to Dr. Nudera. I was supporting them. I would say, listen, I want you to expand your scope. I go out and I teach general dentists how to do endodontics. 80% of endodontics in North America is done by the general dentist. The endodontist only gets 20% of that. So with that knowledge in place, don't we at least want to train our local dentists on how to do endo well? And then when they run into a problem, support them. So will some endodontists scoff at that idea? Of course they will. But there are plenty out there that are willing to help and willing to teach. So the only time that becomes a problem is when you only have one endodontist in your area and they're not willing to help you. Well, then now what do? Well, now you have to look into other resources. Now you may have to get on a plane and go somewhere. National meetings. But there's a lot of webinars. There's a lot of stuff on YouTube that you can really learn a lot of good stuff. But I would think that most endodontists that I speak to, at least in my circle of friends, are extremely forthcoming with their time and willing to share their knowledge to help everybody just do better work.
I know of an orthodontist. Orthodontists share the least. I mean, you get out of dental school, you'd never even done one Invisalign. I mean, they're the most think in fear and scarcity. And an endodontist and an orthodontist in Sydney decided he was going to open up his doors, and all the general dentists doing Invisalign or ortho need any help, and he put on these study clubs and all. He has the biggest orthodontic practice in Sydney, and he has 4 locations: north, south, east, west. In fact, I think he has like 3 orthodontist associates in each one of his 4 practices, and the whole thing was based on, hey, these general dentists are doing ortho and they're horrible at it, so let's start getting them on some regular diet of education so that they're doing
Yep.
what they already do better. But then I have a relationship with them, and now they're referring me all their ortho. I mean, he just crushes. He's probably the richest ortho.
It's unbelievable how that works. Unbelievable. You train somebody how to do things right, and they can recognize maybe what's out of their scope. Because I've gone to my referring dentist office. I've helped them obturate cases. I've helped them instrument cases. I am hands-on I'm really dedicated for everybody to do good work. And I'll do molar endo all day long. I'll do retreatments all day long. I'll do surgeries all day long. That doesn't bother me. If they want to do all the 8s and 9s, certainly I'd like to see those too. But molar endo is my bread and butter. And most of my referring dentists don't do molar endo, but I'm happy to support them if they want to try. And let's say they break a file. Let's say they perp. You know what? Send them over. Dr. Nudera, I'm here to help you. I'm not going to judge you. I'm not, because every mistake that a general dentist has made, I guarantee you I've done more than one occasion. And you know what that makes me? Well, let me rephrase that. So there was a dentist when I was in school that I was referring to as an expert, and this dentist said, you know why I'm an expert? Is because I've made that same mistake more than once. So that's how we become knowledgeable. We learn from our mistakes. We learn from our errors. So when the patient is sent to me, what I'll do is I'll call up that general dentist and we'll figure out why we had that mistake. They correct it the next time. It's unbelievable how much that's grown my practice.
So I want to ask you a bizarre question, but when you say molar endo. When you say molar endo, in your practice, what percent of molar endo is first molar versus second molar versus third molar wisdom tooth?
I would say that the majority of treatments that I do are first molar. I don't have percentages, but just off the
What would
top of
you
my head, my
guess off
empirical
of?
analysis. Geez, I would say probably 60% first molar, 40% second molar. Wisdom tooth, they're few and far between. I saw one today, ironically, but they would be few and far between. I think I can count on maybe one hand per year the amount of wisdom tooth that I treat endodontically. But I would think the first molar is probably the most common one because yes, the tooth we've had the molar we've had in our mouth since the longest. They come at what, 6 years old? So certainly those are the ones that tend to break down first.
And if you have
The most
children,
commonly retreated. Go ahead.
and if you have children, I mean, the home care at age 6 versus the home care at age 12 is day and night. I mean, a 6-year-old can't even
No
tell you what country
doubt.
he lives in.
The most commonly retreated tooth I will see in my office is the maxillary first molar because of the elusive MB2 that gets neglected more often than not. And the good news is that when I do see it and I only see 3 canals treated, I know that I have a really good chance of improving it or getting it to work.
Well, which leads me to my next question. So you said the most common retreat is an MB2, and you wrote a chapter in 3D imaging. So I assume you're talking about those glasses you bought at the back of the what was the little card? What was those little cartoon
The
magazine? What was that called?
the comic books,
The
oh yeah,
comic books.
the X-ray visions,
So
yeah.
did you are these the X-ray vision glasses that you bought at the back of the comic book?
They sure are. They're polarized and they're plastic and I can. It's wonderful.
So so
No,
um
it's.
so does that
Go
does
ahead.
that so is it are we coming faster rather than slower towards a day where standard of care on a maxillary molar endo is to have a 3D image of it?
Well, when we say standard of care, we first of all, I'm not an attorney, so I can't really comment on the legal standard of care, but I have to only go by what I would do and what I would want. I take a cone beam scan on every single tooth that I treat. I will not do a root canal without a cone beam scan.
And which one?
When I
Which
first got
brand?
my cone, I have right now we're using the Kodak 9000 limited field of view. It seems to work well for us. We also have the option to do a full arch with their stitching program. So if I want to maybe do a scan and do a surgical guide for implant placement, I have that option as well. So it's very expandable, which is a nice option. But when I first got my cone beam machine, I was only just like every other endodontist. We're like, well, we're going to do limited scans. We're going to take them for the surgeries. We're going to do the retreatments. We're going to do the resorption cases. Anything that looks strange. So it took me about, I'd say, a month and a half to realize that I need one of these things on every single tooth that I treat. And I know the quality of my treatment is going to be better. I have an undistorted image. The measurements are going to be extremely accurate. I can find more canals. The literature has shown that we can find more canals. There's also a literature publication that was published within the last few years that suggested that the cone beam CT image would change your treatment plan over 62% of the time when it's added to your standard two-dimensional PAs. So there's a significant impact that cone beam imaging has, not just on your treatment, but on your diagnosis and your treatment planning. More importantly, not just what to treat and what to see, but treat smarter, what we don't want to treat. Getting into something that we know isn't going to work. It's been critical. I've got a really nice presentation. It's about an hour to an hour and a half just understanding cone beam. More dentists are having cone beam now. The exposure is moot as far as being worried about overexposing patients to the X-ray radiation. But it's certainly something that I find extremely valuable. It's not going anywhere. It's only going to get better. And will it be the standard of care? I wouldn't be surprised. At this point in time, it's not. But even people within my own specialty are not on board for scanning all the time. But I guarantee you that if they want a root canal themselves, they're going to want a cone beam on their tooth. I would assure you that most endodontists probably would appreciate the value of a cone beam scan.
Well, a lot of it's logistics. How long does it take you to take the CBCT? I assume your assistant does it.
That's right.
and then pull it up on the computer, and then you go in there and look at it. What does that take you? I mean, if your
So
assistant's in
here's
the CBCT, is that it? That's in a separate room, and then it's got to go onto your computer, and then you sit down and numb up this patient, and then you look at the CBCT, or talk about the logistics of that.
all right. So here's my protocol, and so I'm typically scheduling about 90 minutes per visit. I don't care if it's tooth number 8. I don't care if it's tooth number 31. Everybody gets about a 90-minute appointment slot. We call them meet and treats. I do a lot of single visit root canal treatment, and I'm a big fan of single visit if all the parameters are fulfilled within that single visit parameter. The patient comes in, all the medical history, all their logistics are filled out online before they come in. So they walk into our office, they sign their consent forms, they sign their HIPAA forms, then get escorted back to the treatment room. Then the assistant will go over what I call a pre-interview. I call it working up the case. I have a diagnostic sheet that the assistant or the chairside technician will go down a list of questions that I've formulated for them. It's called the subjective exam. And they have to write an answer in the box next to it because it promotes active listening. And then they take 2 PAs for me. They take a bite wing PA and they take a bite wing radiograph and your standard PA. Then from there, they escort the patient down to my cone beam room, and we take a limited field of view of the area of interest. So the patient then gets escorted back to the room. This only takes maybe 7 minutes, 10 minutes tops. I'm in the cone beam room reading the cone beam while the assistant's next to me in my ear chatting me up about the subjective history. So then after I'm reading the cone beam, I'm looking at the tooth anatomy, I'm looking for pattern recognition, looking for any sort of non-odontogenic issues, anything like that. So once I get a good idea of what that tooth looks like, I'm formulating my diagnosis in my head with the imaging and the subjective information. So I walk right in that treatment room and I reiterate in the matter of just a few minutes to the patient what their problem is. I've already formulated my initial opinion. Right there within a very short period of time, I've built so much trust with that patient because I only have a fraction of a moment to build trust with a patient that really is really nervous about this sort of treatment. So I've already gone over that cone beam scan before I've even talked to that patient. And our computers are networked, so I can pull that scan up in the computer right in front of that patient. And it's very important to me that that cone beam scan is there while I'm doing that treatment because I want to look in the tooth at what I'm looking at and look at the cone beam scan internally and have it match. And it's really, really quite helpful. So as far as it being a burden for time, it's not at all because I've worked out a system. And in that 90-minute period, we're generally doing all that imaging, doing our consult, getting our treatment plan signed, getting the patient anesthetized, and doing root canal treatment from start to finish on a molar.
So you said you had an hour and a half lecture on CBCTs?
Yeah, I've got about an hour and a half just how it impacts root canal treatment and how to even read the scan for endodontic purposes.
Because you put up an hour and a half course last year, Selective Root Canal Treatment, a conservative alternative. That was
That's
an
right.
amazing course. Do you think this hour and a half presentation could be course number 2 from you?
It certainly has potential to be.
Okay, we would love that. You know,
Yeah.
Endo is the most active board on Dentaltown. It's endodontics, then pediatric, endo, pediatric, and implant dentistry are 1, 2, and 3. And I think a big part of it is because the patient's begging for treatment, whereas when you go into veneers, bleaching, bonding veneers, and
Mm-hmm.
all on 4, you better be a good salesperson, which you could do with all that good hair and
It's
good
true.
looks. You could have been a cosmetic dentist. I'm usually the best looking dentists don't go into endodontics. Usually they go into cosmetic dentistry. Have you noticed that? You mentioned that when a single visit is indicated, and that you do a lot of meet and greet single visits. When is it not indicated? When do you have to
Couple.
temporize and bring them back?
So I have criteria. Number one, the acute apical abscess, swollen, pain. Anytime that somebody comes in with a lot of swelling for the acute apical abscess, I'm getting purulent drainage, and I can't get that tooth dry because it's sometimes very difficult to get that dry tooth in that single visit. Well, I'm going to medicate that tooth and put some calcium hydroxide in. I'm going to have them back. The emergency patient, because usually I'm running a pretty full schedule. A busy day for me, Howard, is 6 patients, and each of them scheduled for an hour and a half. I'm pretty tired by the end of the day. But now I have to fit in some consults here and there. I've got to line up my day for tomorrow, line up my day for next week, and I'll get an emergency. And our motto here is if a patient calls or a dentist calls and they have an issue, The canned answer is send them on over, because we will get them in and we will see them. So if I have to start something or squeeze somebody in while I'm waiting for my irrigant to soak in a little bit, well, maybe I don't have time to complete the case at that emergency visit, so I'll medicate that case. Bleeding is another indicator for maybe we shouldn't be finishing the tooth at this particular point in time. So basically it's, can I get the canal dry? Have I achieved the disinfection that I feel that I have? And again, that's a subjective comment, but certainly everybody's got their different criteria for that. And a time factor. I'm never in a hurry. I'm never in a rush. And I always tell the patient, not about how fast I can treat this. I'm an efficient clinician. I really try to focus on no wasted movements in that operatory. When you see me work with my assistant's through the scope too. I call it like a choreographed dance. If we drop an instrument, if we run into each other, it's equivalent to a dancer stepping on somebody else's feet. We are so in sync with each other that we are in that tooth from start to finish, and we just don't waste any time. And I find that when I go to other clinics and watch even some of my colleagues, there's a lot of unnecessary movements. And the reason why they're not as efficient is because they're wasting time reaching for a lot of things. So, Howard, I just kind of lost my train of thought with what your question was.
You answered it perfectly. In talking about unnecessary movements, one of the things I like to focus on is the variance. I mean, I don't like to talk about anything everybody agrees on Dentistry Uncensored. But some dentists, when they get a toothache and they say, you know what, I can't do this root canal. I'm sending to an endodontist, but this guy's in my chair and he's in pain, so I'm going to numb him up and I'm going to do a pulpotomy. I can bill out for the pulpotomy. I'll get him out of pain. Then when the endodontist, he doesn't have to have the endodontist start his day. Other dentists say, well, it doesn't need a pulpotomy. It needs a root canal, a pulpectomy. It needs the whole damn thing. And so some dentists do pulpotomies and then bill out, charge, get them out of pain, send them to the endodontist. Some just send them to the endodontist. What's your thoughts on pulpotomies on adult molars when they show up in the office and you have a toothache and you technically can't do this molar endo?
So it's a very simple algorithm, Howard, as how you determine whether or not you want to start the treatment, whether or not you do a pulpectomy, whether or not you do a pulpotomy. So first of all, case selection. Anytime you feel like something is out of your scope of practice, send them out. It's not worth causing a problem or getting involved with something that's over your head. Now, that being said, I always encourage that dental practitioner that wants to expand their scope, try things that are out of their comfort zone. Again, with the support of the clinician that can maybe bail you out if you run into a problem. I mean, when I had to learn implants, I came out of school doing endodontics, and I place implants too. And it was a big eye opener for me jumping into the implant world, because I had to relearn how to extract teeth. I had to learn how to put implants in. I had to learn guided surgery, and I got into some problems early on because of poor case selection. But you know what? I informed my periodontists. I informed my oral surgeons what I was doing. So I knew that if I ran into a problem, I had a support system there. I did the same thing with them that people have done with me, and it works wonderfully. So if we're in a case with an emergency, a patient that comes in with pain, we choose a case. We assume that the case is now deemed within the scope of our practice. So now it comes down to, well, how am I going to manage this emergency patient? Do I do a pulpotomy or do I do a pulpectomy? And it comes down to pulp status. And that's it. If the pulp is vital, you can get away with the pulpotomy. Just take out the coronal portion of the pulp, control the bleeding. You don't even need to use former creosol. I haven't used former creosol in over a decade. You can use ferric sulfate. Anything that can control bleeding would be fine. Put a cotton pellet in there, close it with Cabot. Patient's going to feel better probably over 99% of the time. Certainly there's always that patient that doesn't feel better, and then we take it to the next step. On the flip side, let's say we open this case and now the pulp is necrotic. A pulpotomy is not going to work, because you're going to need to remove the noxious stimulus from the root canal systems. Therefore, we do the pulpectomy. So vitality equals pulpotomy, necrotic equals pulpectomy. And that's kind of how we manage those.
When I was little and got out of school in 1929, and by little I mean 75 pounds ago, 29 years ago, the press was beating up all the doctors because we were mean and insensitive and wouldn't prescribe pain controls. And they had, the ABC Evening News. They had all these, back when it was only 3 news stations. Everybody was talking about, this guy's going to die anyway. He's got cancer, and they won't even give him Vicodin or Percocet or whatever. And we were the bad guys. So then the doctor said, all right, we should treat pain and start giving out narcotics. Now we're the bad guy again because we're giving out too many narcotics and they're blaming addiction on doctors and all this stuff. So the question is, on Dentaltown, some people try to shame other people that use Vicodin or narcotics and say, I've never used it, I never use it, and that's bad, and that leads to addiction and death. And when Prince died, it was a mushroom cloud of opioid addiction discussion. And then other dentists said, I don't give a shit. You do a root canal or pull someone's wisdom teeth, they need Vicodin. What's your view of opioids?
Well, simply, I use them. I use them very sparingly. I would say that maybe 1 to 2% of the time I'm giving an opioid. And generally, it's as a precaution, just in case I think that they may have a reaction that goes beyond the management of your non-steroidal anti-inflammatories, Advil, acetaminophen, something like that. Most of the time, most pain, post-operative pain, is due to inflammation, noxious tissue stimulus, bacterial involvement, all these things that opioids really don't do much for at all anyway. So generally, if I'm dealing with a severe pain issue, my first choice is not a narcotic, although again, I'll be honest, I've prescribed them. I think we all have prescribed some at some point in our career, but I don't rely on them. So let's take the example of the emergency patient again. Let's say we're in a position now where somebody comes in, they've got a canine space swelling and they're swollen out to here and it's indurated. You know that patient's going to be hard to anesthetize because of the tissue inflammation. They've got a tooth that you can't really touch. They need endo, but you can't get them numb. Well, how are you going to manage a situation like that? Narcotics aren't, and then the patient comes in, they're already taken Norco, and they're telling you it doesn't work, it's not solving their problem. So if we take an example like that and understand the pharmacology of how to manage that patient, we can then translate that to our postoperative pain management with endodontics or our flare-up management with endodontics. So here's the protocol that I will use, because I don't do INDs on canine space swellings that are indurated, because that's only going to add insult to injury. The only time I'm INDing a swelling is if it's fluctuant, if it's squishy, if I know I can poke into it and get that drainage. Because if it's indurated, all I'm going to do is cut into inflamed tissue and get a lot of bleeding, and they're going to be even more sore when that anesthetic wears off, if it even worked at all. So how I manage that patient is I'm going to put them on an antibiotic, because there is a bacterial involvement, a bacterial infection. So I'm going to control the bugs with some sort of antibiotic. My antibiotic of choice is, for a non-penicillin allergy patient, is Augmentin 875 BID for 7 to 10 days. It's great. A lot of dentists go to the amoxicillin 500 milligrams TID for 7 to 10 days. But there's a little bit more resistant bacteria now. And there's a generic form of Augmentin available, so it's not terribly expensive to prescribe. So they're going to get that. But it does take a little bit of time for that antibiotic to really get into their system, to really give them that relief. So the other thing we have to understand is, why are they having the pain? It's because of the influx of the neutrophils or the PMNs to the area. And when these PMNs, they have a very short lifespan. They can survive maybe for 5 hours, sometimes 12 hours, sometimes 24 hours, and then they undergo apoptosis. So when these phagocytic cells go to this area of injury and start mopping up all these germs and bacteria, what they use to break down these bacteria is hydrogen-based compounds, like almost like a hypochlorite type of substance. So when these cells undergo apoptosis, what they do is they release all those cellular contents into that tissue space, and it's almost like they're getting that hypochlorite effect, as if you were to squirt bleach beyond the apex. That's what's causing the pain. Attracts more PMNs to the area. Now you've got a significant tissue inflammation. So how do I counteract that? Methylprednisone, a steroidal anti-inflammatory, something like a Medrol dose pack. So if we can attack the inflammation with a prednisone sort of prescription, piggybacked with an antibiotic, well, now what I'm doing is I'm addressing the inflammation and I'm addressing the infection. So you're familiar with the Medrol dose pack, correct?
Right.
Okay, so here's how I would write the prescription. When it comes in a blister packet, and you take the 6 tablets the first day, 5 tablets the second day, 4, then 3, then 2, then 1. So as you're moving through the 6-day cycle of this medication, you're taking less and less of it. So on the package, it's generally easily marked as far as when it wants you to take the medication, how many tablets it wants you to take at that particular time of day. So I instruct the patient When you get this med draw from me, you're going to take all 6 tablets that are associated with the day 1 dose stat. You take it right away. I don't care what that package says. For day 1, you take 6 tablets. And at the same time, you're going to be taking the antibiotic during this time frame. Starting on day 2 through 6, well, now they're going to follow the directions of the package. So what this does is by taking all 6 tablets associated with the day 1 dose, you're having a bolus dose of methylprednisone in their system. And they're 4 milligram tablets of methylprednisone. So really only giving them 24 milligrams of methylprednisone. It's not a lot, but it's enough to counteract this inflammation response. I've had people with irreversible pulpitises and acute apical abscesses respond extremely favorably to this regimen, and they bring their 10 out of 10 pain down to a 2 or a 1 within as little as 2 to 12 hours in the vast majority of cases that I use. And it's non-narcotic. It's a wonderful technique.
You are so sharp. So basically, you don't use the opioids 98% of the time. So what is your
No way.
So what is your go-to average post-op for a molar root canal?
So first of all, I start managing post-operative discomfort before I even start my case. So part of me working up the case with the patient is helping them understand what's going on, why it's happening, what their options are, what the prognoses are with each option, and being the fact that I can do the root canal or take the tooth out, graft the side, or do the implant, I'm completely not. So I'll certainly give a non-biased consultation based on what that patient wants to do, what they feel their best interest is. Certainly my focus is to save the natural dentition, but that's not everybody else's focus. My focus is also to treat a disease process. So however we get from point A to point B, I'm perfectly happy with it. But if they choose to move forward with root canal treatment with me, I start saying, well, here's what we can expect after this anesthetic wears off. And I usually give what I call the 10-80-10 rule. And by the way, it's something I made up. There's no literature on a 10-80-10 rule, but it's convenient for me because it helps patients understand what to expect. So here's my phrase. I say 10% of my patients, when the anesthetic wears off, have an instant improvement. Everything goes back to normal just fine, and you feel like $1,000,000 right away. And I say, I hope you fall in that 10% category, but realistically, that's only 10%. 80%, which is most likely category you're going to fall into, mild to moderate discomfort, soreness, tenderness to chewing and biting, and we're just going to have to allow this area to heal. The healing phase may be a day, it may be a couple of days, it may be a week, it may be a couple of weeks, and most likely it's going to hurt to chew and it's going to be a little sore and bruised. The remaining 10% are going to have a more significant reaction to this treatment, which may require a prescription of antibiotics. It may require an anti-inflammatory. It may require some other augmentation to our regimen other than what I'm going to recommend. And typically, we're managing most of our post-operative discomfort with 600 milligrams of ibuprofen before the anesthetic wears off, on the clock, every 6 hours for 2 days, pain or no pain. If they have an ibuprofen allergy or aspirin allergy, now we're going to acetaminophen. They can take 1 or 2 extra strength Tylenols, which is 1,000 milligrams every 6 hours to a maximum ceiling dose. I think it's 4,000 milligrams, or maybe they change that to 3,000 milligrams. We try to maintain within the confines of the of what their liver can handle. So I usually say 1 500 milligram tablet every 6 hours as needed, but if it's really uncomfortable, you can bump that up to 2 initially to 1,000 milligrams of acetaminophen if you need to. If they're really, really uncomfortable, before I go to the narcotic, and even before I go to a Medrol dose pack or something like that, I will consider alternating 600 milligrams of ibuprofen with 1,000 milligrams of acetaminophen on 3-hour intervals because they work in a little bit of a different capacity. And that can certainly have benefits for the patient as well.
Back to post-operative pain. It seems like there's only 2 kinds of dentists on earth that do root canals. There's either the pulp lovers that like to stay a ½ millimeter short and they just love that pulp and all that. And then the other half is the apical barbarians, and god dang it, it just doesn't feel like they did a good job unless they get a puff of sealer out the apex. Are you a pulp lover or an apical barbarian? And does that affect post-operative pain when you have a puff of sealer out the end of your root canal, and that's what you're looking for to get an A on your root canal?
I'm the latter. You can call me an apical barbarian. I am long on every single case I treat. Does that mean that my patients have more postoperative sensitivity? Not in the least. I've been going long on every single, first in dental school, I kept it in the confines because that's what we were taught. But as we understand that we want to clean not just to the tip of that apex, but slightly through. I'm not talking about blowing out our apex. I'm talking about being patent with maybe a size 1502, maybe a 2002. I know some endodontists that are patent to a 25 or a 30. That's a little big for me. But I could go to a 20. I advocate to a 20. I have now recently stepped back to a size 15. But let's say I'm out 1 or 2 millimeters with a size 15 by virtue of the geometry of the file that's enlarged the apical foramen at least to, what's, a 19, so close to a 20. I'm extremely comfortable doing that. If I see a puff, great. I love it. If I don't see a puff, great. I love it. I don't need the puff. Does it cause more sensitivity? No. In my opinion, it does. I've not seen that in the 17 years I've been practicing dentistry. I think a lot of it has to do maybe with the types that we're using. If you're using a like Ross 811, Ross 801, it takes a long time for that stuff to set. It's really, really cheap. We can mix tubes and tubes of it for pennies on the dollar, but it takes a long time for it to set. It washes out, and I think the setting time of the sealer may have some impact on post-operative sensitivity. Again, I don't know if this may be empirical information I'm giving, but the newer sealers, the bioceramic sealers, they take less time to set up. They're more bio-inert, and if I see a puff of an MTA, I'm doing an apex of 4, if I'm using an MTA or some sort of bioceramic type sealer, it doesn't matter. That what matters is creating the seal.
What's your sealer of choice?
I'm sorry, you broke up. Ask that question again.
What is your sealer of choice for your standard root canal?
I'm using the Brasseler product, BC pulp canal, or the BC sealer. That to me is the number one product for me right now.
The Brasseler what?
Brasseler BC sealer, the bioceramic sealer. It's the Brasseler USA brand. There is really only a handful of players right now.
Sealer, BCS, bioceramic sealer?
Correct. Whatever the Brasseler brand is, I believe I'm giving the name correct.
Right.
But there's only really 3 players in the bioceramic sealer game right now. You got Septodont, they've got their BioRoot. You've got Dentsply that's just introduced their MTA seal. I have not tried the Dentsply product yet. I have tried the Septodont BioRoot, and then you have the Brasseler. So the reason I've kind of gravitated to the Brasseler product is because that's the only company that's figured out how to put the sealer in a syringeable suspension. So it's already pre-mixed, it's already ready to go. Not that the other ones, competing ones, are bad. They're all going to do the same thing, and they all have very similar properties. But do I want to sit there and mix it on my mixing pad? And if I mix it on my mixing pad, how am I going to introduce it into my canal? Whereas I can just put a lure lock tip on my Brasseler BC sealer, and I squirt it in my canal. I can do a single. I'm not opposed to single cone. You're going to hear a lot of endodontists say, wow, single cone's bad. I'm not opposed to single cone if you're using a bioceramic type sealer. In fact, I believe that when these bioceramic sealers were first introduced, they didn't even want gutta percha in there. But because we want some sort of retreatability, then we had to put some sort of core that we could regain access to this canal. So all with BC sealer, that would be great. There's also another obturation technique called the Lowati technique. Have you ever heard of that?
The Lowati technique, no.
Lowati technique is a way of obturating the root canal system with pure MTA, white MTA. What they do is you mix the white MTA with phosphate buffered saline, and you mix it in a yogurt-like consistency, and you take a Lentillo spiral and you spin it into your canal, and you pack it with nickel titanium hand files as if you were just doing some sort of warm vertical compaction, but you're using MTA. Now, that's a terminal obturation procedure. That's going to set up like a rock. You're never going to be able to retreat that. But if you get good at that technique, I mean, there's very few cases that will come back that I'm retreating my own case. Now, some I do, but most of the time, if something is not going the way we want it to, I'm going to probably take that to apical surgery as opposed to retreating, unless there's some obvious issue happening within that root canal system. So by using a Lowati technique, we can obturate, and I've used this technique for what I consider a phase 1, phase 2 approach. If I know that there's a ledge inside this canal, and I know that there's a lesion around the root system itself, and I'm still going to advocate removing the internal bacteria because that's where the source is coming from, although there's a ledge, and I know I can't get to the apex, I'm going to treatment plan that case for a retreatment immediately followed by apical surgery. So during my my treatment of that root canal treatment of phase 1, and this is all done the same day, I'll remove all the old gutta percha, disinfect, and I'll use the Lawati technique, and I'll put MTA, I'll pack that into the canal.
How do you spell Lawati?
I'm going to just spell it phonetically, Lawaty, something along those lines.
Okay.
I can email you the reference if you want. I can do it later. But it's a really good technique. So I'll use this Lawati technique and then immediately surgerize. Now I've already got my MTA in that canal. I no longer have to do any sort of retro prep or apical fill because I just section off the root and it's there. Now, if I section that root during the surgery and I see an isthmus, well, I'm going to go ahead and I'm going to prep into it and I'll add a little bit more to that particular area. It makes treatment go so efficiently. And these combination treatments that I do of a phase 1, phase 2 endo treatment are some of the most definitive treatments because not only are we addressing the internal etiological component, we're also simultaneously the same day treating the external etiological component. People heal well. I graft my osteotomy. I put a membrane in there, and these things are extremely successful.
Well, that is amazing. You heard it here on Dentistry Uncensored, a technique I can't even find on Google. You said something very interesting. Dentistry Uncensored, I like to talk about things that are no one agrees on. You know what I mean? There seems to be a big a lot of general dentists think this. A lot of them say, you know what, I like these single cone gutta percha on a stick, like a thermofill. They're just fast, easy, bam. Other people sit there and say, dude, you shouldn't do that because that makes it harder to retreat. Do you think the single cone with gutta percha that you warm up, gutta percha on a stick, does that make it harder for retreat? Because when you talk about this Lawati technique, the first red flag to me is this country has 1 million attorneys. There's only 200,000 dentists. I would think an attorney, if you obturated a tooth that had no retreatability, that's going to be bad because the literature is very clear that at least 5% of molar root canals fail in 5 years if they're done by an endodontist. You think it's higher?
Higher probably. Yeah.
Okay, so higher. So you can't do a technique that's not reversible if you know the failure rate is going to be at least 5% in 5 years. So do you think as an endodontist, is it harder for you to retreat a failed thermofill than, say, a lateral condensation?
So there's a couple of questions within this question here. So let me address carriers.
That's because there's multiple personalities in my head.
These carriers.
There's
well, I'm going to try to address this all.
There's several people living in my head, and they're all trying to get a question out.
So let's talk carriers here. I've placed my fair share of carriers as an endodontist. I'm not against them. I think they're great obturation. It's a great obturation technique. I fell into this, I guess, this group of clinicians that would always retreat a tooth. All of a sudden, I open the case up, see those little black dots with gutta surrounding it in the canal and say, oh, this is why it's failing, because it's a carrier. But really, it's not the carrier that causes anything to fail. It's the lack of proper irrigation, lack of proper shaping, or there's something that led it. The obturation is overrated. Obturation, it may be looked at sometimes as just this radio-opaque marker that helps us tell how well we shape this root canal system. Because we've all seen those really poorly root canals done that work next to really well root canals that look beautiful that fail. So I don't think that endodontics isn't necessarily an evidence-based treatment. It's really more like an evidence-based philosophy. Because until we figure out how to sterilize those root canal systems, we're all just doing what we can to entomb and remove as much bioload as we can. So the fact that we can't blame failures on carriers. We blame it on either biology, uncontrolled biological factors. Now, does that mean it's harder to retreat? Not in my hands, because there's techniques. It's something called the carrier launch technique. In fact, it was taught to me by a friend of mine, Steve Buchanan. I've been really lucky to have a lot of good mentors in this specialty. And the headstrom, it's called the headstrom launch technique. And what you'll do is usually if it's a carrier, there's going to be a little bit of ring around the carrier, the dark carrier. You're going to see gutta percha, pink around it. So you're going to take a small size file, maybe a 2008 or a 2006. You're going to get purchases around in the gutta percha around that carrier, that internal carrier. And all you need to do is get down to the mid-root. And then you start with maybe a size 30 headstrom file, and you begin engaging, turning it clockwise, using that headstrom, that corkscrew geometry of this file, and that will engage in that plastic carrier. Once you get to about mid-root, you've got to keep your eye on that handle, because as you spin that handle, if it locks into that carrier and you keep spinning it, you're going to break that file. So I'm twisting the file, and as every so often I'm just giving a little turn, I'm letting go. If I see that file rebound back in the counterclockwise direction, that tells me I've engaged it enough, because if it rebounds, that means it's locking in somewhere. Do you follow that?
Yeah.
So far? Okay, so then once I have that engaged in the carrier, I'm going to take a curved hemostats, I'm going to take my file, I'm going to clip my file, use the tooth as leverage, and slowly leverage that carrier out. They come out really in seconds. It's not challenging to retreat. I know it's easier said than done here, Howard, and I do this all the time, but it's a technique that I teach the residents at the University of Illinois, Chicago, and it takes a while to figure it out. But once you figure it out, that light bulb goes off, and their carriers are not any more difficult to treat than a standard gutta-percha case. And in fact, once those carriers are out, your guide path is already there. All you have to do is remove the residual gutta-percha. So there are some that are more challenging than others, but those are very few and far between. And I think the reason why I've gotten so accustomed to being able to remove these so readily is because I've actually used them in practice as well. And I'm very familiar with how these things behave. And I think there are clinicians out there that are afraid to use it because of the bad press that some of these carriers have gotten over the years. But when we look at our current literature, the press is improving about publications coming out suggesting that they're not terribly terminal obturation procedures, and they can be retreated very easily.
Now let's get into some real skeletons of the closet, dentistry, uncensored things we shouldn't talk about. You said a Freudian slip. You said, you have an unbiased deal because you can retreat the root canal or you can pull it and place implants. Some general dentists get mad at their endodontist because they'll send a tooth over there and they'll say, can we save this or should I pull it? And then they'll say, you know what? He always tries to save it. But then a year later, a lot of them end up getting pulled anyway. And he said, well, I did all I could do. And then they think, well, if your only tool is a hammer and everything looks like a nail and you got to feed your family, you got to do this many root canals a day, do you think endodontists are less biased if they say, look, I can feed my family two ways. I can do a root canal in this tooth, or I can pull this tooth and place an implant. I make my money either way. Do you think the average 324 million American consumers would get better diagnosing and treatment planning if every endodontist could do the molar endo or place an implant? Or is that just, what is your thoughts on that?
Well, I practiced endodontics for many years before I decided to go in the implant direction. And I always would, anytime someone would come up and approach me about my interest in doing implants, my answer was, well, I didn't get into endo to do implants, or you can't really be profitable as an endodontist doing implants. But you actually, there is a way to actually add that to your treatment protocols and actually benefit the patient. The question is the endodontist biased in only recommending the retreatment because they don't know how to do the other procedure? Well, there may be some truth to that. We tend as clinicians to only recommend procedures that we're comfortable doing or that we're competent in doing. And if the endodontist thinks that the tooth is treatable, well, then certainly we have to try to save it. But, if you're making decisions based on finances only, well, that's an ethical decision. And I'm not so sure that even when I wasn't placing implants, I would still give my patients the implant option. So, we can teach ethics, but it comes down to integrity too. So we have to always look at everything non-biased, regardless of whether you do the implant or not. We have to put that on the table as the option for the patient. I am fortunate now that I place implants that I can offer both options. Is my opinion biased? No, it's not biased at all. And now what we have to do, if you're going to start placing implants as an endodontist, you have to put those phone calls into your general dentist. I'm never taking a tooth out unless I have permission from my general dentist. I've had to work very hard in my community to establish myself and my reputation as now an implantologist and an endodontist, and that didn't happen overnight. I'm still trying to build that aspect of my practice. Not all my referrals want me to place the implant. There are many that do, but not all of them do, and I have to respect that. So if they only want the endo relationship with me, that's fine. If they only want the implant relationship with me, that's fine. But my business model of how I've gotten to develop that within my practice is also a little bit unique in the sense that I always focus on trying to save that natural tooth. So let's say somebody comes into me and we're offering the retreatment as the first most conservative option. And the patient's like, well, I just went through this. I don't know if I want to do this anymore, but I really believe that there is an option to try to save this tooth. I will always present, well, let me try this retreatment for you. It's going to be X amount of dollars. Your insurance is going to cover this much. Your out-of-pocket expense is going to be this much. And let's see if we can't get this tooth to survive. Let's see if we can't get this to work. And I'll tell you what, if it doesn't work and you're still symptomatic, or the bump doesn't go away, or the lesion doesn't heal, I'm going to take your out-of-pocket expense that you paid me to do that retreatment, and I'm going to carry it over to your extraction, your graft, and your implant. So you're not losing any out-of-pocket money for me to try to save your tooth. And we're helping you invest in the foundation of your natural tooth, if not the foundation of the artificial implant. So they're not losing, and it still focuses my mission statement of trying to preserve the natural dentition and try to give that tooth an option to succeed.
What implant system did you go with? Did you go with multiple because you have referring dentists, or did you just stick with one system?
Well, that's a good question. And so here's what I figured out, and this is uncensored, so I'm going to be very frank with what I'm choosing to do. So my implant system mainly is have you ever heard of the OsteoReady implant system? It's Brady Frank's implant system.
Absolutely.
It's been on the market for a few.
Out of Seattle.
Yeah, so I'm using that that was my main implant system that I started with. Now I have the Ankylose kit as well, but being the specialist, I can't choose the implant. I have to choose the implant the referring dentist wants to restore. So now what do? Do I go out and buy 10 different kits? Do I have every single implant company here in my office? Well, I can't do that. That's not practical for me either. So I relate this to endo. So if I'm using one brand of a file, does that mean I have to use their gutta percha and their paper points? I don't. I can use one brand file. I can use another brand paper points. I can use another person's brand gutta percha. And guess what? They're all going to work to some degree. So if I want to do a Nobel, 4.3 by 11.5, all I have to do is find an osteotomy drill that's close to that size, regardless of who makes it. I just have to make the osteotomy that particular size. So I have basically what I consider to be a universal kit. And if the dentist sends somebody over to me and says, I want this type of implant, well, I'll just call that company. I'll order the size implant I have, and I'll find the osteotomy drill that fits that particular implant size, and I'll be able to put it in just fine. All it is it's an osteotomy. So all we have to do is get those diameters and the dimensions to fit the implant that I'm placing without having to buy somebody's whole system.
And do you freehand eyeball that, or do you use a surgical guide?
I'm doing a surgical guide. I mean, I know there's a lot of great implantologists out there that freehand everything, and they do beautiful, pristine work. Well, I'm not that good. I want things to be absolutely perfect, and I am still learning, Howard. I'm still learning implants. I don't know implants as well as I know endo. So just like the general dentist who's expanding their practice with endo and picking and choosing the cases they feel within their comfort zone, well, I'm doing the same thing. If I get a case that I don't